Hi there, everyone. My name is Tori Schacht, and this is my presentation on antibiotic stewardship for SSTIs in pediatric urgent care centers. My committee members were Dr. Elizabeth Buck of Maryville University, Dr. Boniface Stegman, also of Maryville University, and Dr. Patrick Dolan, who is my community chair in my workplace. Background. The purpose of this scholarly project was to improve antibiotic prescribing practices in national pediatric urgent care centers based on evidence-based practice for the pediatric patients who have skin and soft tissue infections, including cellulitis, impetigo, and paronychia. A revised clinical guideline to promote best practices for providers when prescribing for SSTIs was implemented. This doctoral project aimed to reduce the amount of unnecessary antibiotics consumed and targeted utilizing more appropriate antibiotic selection through standardization of care based on extensive literature review. The project implemented interventions and measured adherence to the revised guideline to assess the company's impact on antibiotic stewardship for SSTIs. Review of literature. An extensive literature review was conducted and led to three major themes: evidence and variability in prescribing practices, selection and duration of first-line antibiotic choices, and quality improvement. Evidence of variability in prescribing practices was noted in emergency departments and pediatric urgent care centers that prescribers have variability for their prescribing practices for SSTIs, including cellulitis, impetigo, and abscesses. National guidelines from the Infectious Disease Society of America and institutional guidelines are cited as the standing guidelines in many studies. Even with these in place, there is much variability in prescribing practices. Selection of first-line antibiotics and duration of antibiotics. Changes in first-line antibiotics proved to be effective by not having a return rate of treatment failure outside of baseline. The same is true with shortened duration. For quality improvement, antibiotic stewardship can be encouraged and reinforced. Interventions that help change prescription duration were education, feedback, clinical decision support, hard stop messages and electronic medical records, new order sets, maintenance of certification credits for participation in the project. The theoretical framework that this project is based around is called Antibiotic Stewardship Nursing Practice SCAN-P framework. This framework focuses on goals of antibiotic stewardship, including promoting health and safety at the individual and community levels. And this is from Manning et al., 2022. The framework's key elements are monitoring prescriptions, implementing quality improvement and safety interventions, garnering support, utilizing present culture and structure to foster these improvements, as well as being competent with antibiotic stewardship and educating on its needs with providers, patients, and families. This DMB project on antibiotic stewardship for skin and soft tissue infections will utilize these key elements as well, which it did. Through clinical guideline changes for SSTIs, providers have a resource for assisting with their clinical judgment and making appropriate antibiotic choices. Monitoring these prescriptions through our audits and making sure they align with antibiotic stewardship is paramount to keep patients safe from the harms of inappropriate antibiotic usage while effectively treating their infections. In a collaborative quality improvement project, regional medical officers have been recruited to help facilitate and monitor changes within their clinics. Education and interventions was offered at monthly webinars for these regional medical officers to disseminate to their providers. A framework is a conceptual basis for a research study. This framework aligns with the CDC's core elements of outpatient antibiotic stewardship. This framework defines key structures for antibiotic stewardship and how a doctoral nurse practitioner student can propel these interventions. It helps to answer the question of inquiry for this project. Through quality improvement, how can the pediatric urgent care centers align their prescribing practices for skin and soft tissue infections, cellulitis, impetigo, and paronychia, with current best practices to improve antibiotic stewardship? Methods. Data for this project was retrieved from retroactive chart review of electronic medical records of patients who have visited a chain of pediatric urgent care centers in the United States in 2024 through 2025, who were between the ages of 2 months to 26 years old and had a diagnosis of cellulitis impetigo or paronychia and were eligible for topical or oral antibiotic therapy. Participants may have been of any gender and ethnicity. The company data analyst compiled de-identified charts into the system CLIC by searching International Classification of Disease ICD-10 codes. Charts were then sorted by clinic location, diagnosis, treatment prescribed, duration of treatment. Providers at all clinic locations were recruited for participation. They were offered the opportunity to learn, be involved in quality improvement, and receive maintenance of certification credits for those who are American Academy of Pediatrics certified pediatricians. Providers audited charts for this company-wide clinical guideline compliance. Monthly webinars were hosted to discuss progress, as well as intervention options that the clinics can perform, and we did a plan, do, study, act cycles. This data collection occurred over a 9-month period of time, and the process reviewed 3,334 charts. The sample included, like I mentioned before, patients 0 to 26 years old, but they must have been greater than 2 months of age. They needed to be diagnosed with an SSTI via ICD-10 code, cellulitis impetigo, or paronychia, and they were excluded if they had systemic symptoms that would warrant them being transferred to the emergency department. Data analysis. Descriptive statistics were utilized to organize and analyze nominal data that was collected. Descriptive statistics amalgamate the data and format it into an understandable way. The prescribing variability from the revised clinical guidelines was assessed by converting the nominal data of antibiotic type and duration prescribed, as well as if there had been a previous treatment failure to determine overall compliance improvements. Change in compliance for impetigo prescribing showed an increase from pre 53% to post-implementation of 62%, which I'll show you in Figure 1. Change in compliance for paronychia also increased from pre 53% to post-implementation 73%, which I'll show you in Figure 2. For cellulitis prescribing duration and antibiotic first-line choice, there was no change post-intervention. So the results can be seen here in this figure, which is pre versus post-intervention compliance for impetigo prescribing. The compliance we had pre was 53%, and we had an increase in 9%, so up to 62% for post-interventions. Compliance for impetigo prescribing was based on facilities' clinical guidelines. It was considered compliant if the patient had one or localized lesions and was prescribed mupirocin only, if the patient had multiple and widespread lesions and was prescribed the first-line oral antibiotic, or if they failed treatment and were prescribed the oral antibiotics, or from first-line to second-line antibiotics for failures. Figure 2 shows pre versus post-intervention compliance for paronychia prescribing. We went from 53% initially to 73%, a 20% increase. Note, compliance for paronychia prescribing was based on facilities' clinical guidelines. It was considered compliant if the patient was prescribed mupirocin or if the patient had cellulitis in conjunction with paronychia and was prescribed the first-line oral antibiotic. Table 1 shows us pre- and post-intervention compliance rates for all 4 metrics that were measured during this study. So metrics were selecting cephalexin as first-line antibiotic for cellulitis, selection duration antibiotics 5 to 7 days for cellulitis, reduction of unnecessary oral antibiotic consumption for impetigo, and reduction of unnecessary oral antibiotic consumption for paronychia. There was no changes in the first 2 metrics, pre versus post interventions, and we showed improved compliance rates for changes with impetigo and paronychia. Limitations. Limitations of this study include that retroactive chart auditing is based on extracted data from the electronic medical record, and it requires that the provider documenting is doing it correctly and thoroughly to draw conclusions of appropriate prescribing. If they did not document the number and location of lesions for impetigo, it makes it difficult to determine if the patient sufficiently meets criteria for oral antibiotic prescription or not. Another limitation of this study is that improvements were made for 2 out of 4 metrics. The metrics that showed improvements were the ones that required active chart auditing for impetigo and paronychia, whereas the metrics for cellulitis, first-line antibiotic choice and duration, were just directly pulled from the EMR and placed into the dashboard. While metric progress was disseminated monthly, more active QI, quality improvement engagement, was required of regional medical officers to promote changes in their respective clinics in regard to cellulitis. Possibly chart auditing inspired more change as it was felt as more tangible to make these positive changes. Discussion. This study showed improvement in 2 out of 4 metrics. There was the ability to promote and improve antibiotic stewardship and guideline compliance. The results showed 9% improvement for compliance of oral antibiotic prescribing for impetigo and 20% for paronychia, whereas there was minimal changes for cellulitis first-line antibiotic selection and duration. The revised clinical guidelines had been released 10 months prior to the start of this project. Cellulitis first-line antibiotic choice and duration had already seen improvements with just the release of the guideline prior to project implementation and measured around 70 and 59% compliance levels at baseline, and the baseline had already gone up to 75% for first-line choice and 66% for duration with just the implementation of the guideline itself. Implications for practice. Antibiotic resistance is an ever-growing public concern. Reducing unnecessary antibiotic consumption is one of the best ways prescribers can help to combat this issue. Safeguarding the use of antibiotics to only when it is necessary is so crucial. The findings of this study show that it is possible to do this for SSTIs in the pediatric urgent care setting. Effective treatment with the least amount of antibiotics is necessary is achievable. Continued practice in antibiotic stewardship prescribing is paramount. Future research in antibiotic stewardship quality improvement should be conducted. The results of the study show that further knowledge is needed for continued improvement. Changes were able to be made for impetigo and paronychia, but not for cellulitis. Understanding the reasoning for this and making changes is important for future success. It would be imperative to track the number of return visits based on the new guideline to determine if there are more, less, or the same number of treatment failures. So our goal is to safeguard antibiotics, reduce community threat of antibiotic resistance, sustain and promote continued improvement. Conclusions. This project has determined that there is clinical significance and quality improvement to reduce unnecessary antibiotic consumption for impetigo and paronychia, and further assessment and intervention are required for further improvement of cellulitis first-line choice and antibiotic duration. Recommendation is for further intervention and monitoring for the sustainability of the work done to improve antibiotic prescribing. Further recommendations are to extrapolate this work to other instances where antibiotics are prescribed. This project has had a massive personal impact on me and my future career as a doctoral nurse practitioner. While I've always appreciated evidence-based quality improvement, I have not had the opportunity to lead an endeavor such as this until now, and it has been with great joy and a lot of hard work to accomplish this. This project has made me a better collaborator, leader, researcher, and advocate, and I plan to continue to perpetuate this in my practice and in my place of work. Thank you so much for listening to my presentation. These are my references.